Hi, and welcome to this presentation. Thanks for joining. It's a great pleasure and honor to speak here at the MIUA conference and talk a little bit about some of the works we've been doing and some of the thoughts we're having. What do we need to get towards safe AI in medical imaging? So just some disclosures. So I work with a few companies. So at Imperial College London in the Biomedia Group, basically everyone, the PhD students, researchers, academics, work at this intersection of machine learning and medical imaging. So many of you will work in this exciting place where we try to make contributions on the methodology side, coming up with new ways of using machine learning, and eventually, hopefully, get this into clinical practice. So I want to talk today a little bit about some of the challenges and difficulties we might come across when getting these techniques into real-world clinical use. So if I have to categorize the research that we are doing in my team, I could use these 4 categories roughly. So we do a lot of work on building algorithms for semantic imaging. So for instance, using neural networks to do brain lesion segmentation. So we've been using a lot this architecture DeepMedic that you might have come across. We have a few works on image-based detection of disease, so trying to detect and quantify pathological structures in images. And there's more and more work in my team around this area of robust and reliable machine learning. And that's a key part also for this talk that I want to talk about in a little bit more detail. And then there's work on the more methodology and theoretical side of things. How do we design new types of learning strategies, how to combine labeled and unlabeled data, and so on. There are a few online demos as well. So if you want to see DeepMedic live in action doing brain lesion segmentation, please do also check out our demos. So when I look at what is required to build safe AI, of course, I have a very biased view, and this is a perspective from a computer scientist looking at a machine learning path, getting from input data to output predictions and how they are being used. Obviously, I'm not a researcher in safety and safe and secure systems. So of course, there's a whole aspect missing here that is looking at the more safety critical aspects of developing technology. But what I do think is that we also have a responsibility to carefully think about how we can make, for instance, image analysis algorithms more safe. And the way I see it is that there is not just the algorithm that is at the center that we need to focus on, but also components that are maybe sitting around that algorithm. So for instance, I think we should think more carefully about what type of safeguards can we put in front and after an algorithm, for instance, to look at the inputs and the outputs. Do we need automatic quality control methods that can look at input data and check the quality, check that it's compatible with our algorithm, that it's valid data that is being passed on to the algorithm for analysis. And then also looking at the outputs, so the predictions that come out from a machine learning model. Can we say anything about how reliable these predictions are? Can we automatically detect if there are failure cases or failure modes of an algorithm? And can we do this automatically? So putting some output safeguards here. And I think this is really important, especially in the setting where we have algorithms which are on their own maybe less interpretable and understandable for a human expert. So we need to have some mechanisms in place that allow us to have some extra safeguards. And of course, the algorithms itself, we can try to improve by adding robustness and reliability. And I want to talk about this a little bit more next. But then there's also this whole aspect about transparency and explainability. What does it make that everyone being involved, the patients, the doctors, regulators, policymakers, that we can gain trust in using this new type of technology? And I will talk about this a little bit, although we haven't done a lot of work on this yet. So let me first talk about robustness and reliability. First of all, maybe it makes sense to talk a little bit, what do we mean by these two terms? Everyone might have slightly different definitions in mind. So let me give you my view on this. So robustness for me concerns an algorithm's ability to preserve its predicted performance, especially under variations in the input data. And this is a big topic. Many people are working on this. How do we make sure that, for instance, an algorithm that detects disease in medical scans works equally well across different scanners different settings of image acquisition. Reliability, on the other hand, for me concerns the question whether one can trust the algorithm's output predictions. And this is really, really important in critical tasks such as clinical decision making. Ideally, an algorithm should be able, for instance, to communicate its confidence in its prediction. It should raise a flag when the algorithm doesn't know, right? So when the algorithm thinks that the data isn't analyzable and the prediction should be discarded, it would be good if the algorithm can tell us. So let me first talk about some works we've been doing on trying to improve robustness. There are two main streams here. We can look at domain invariant feature learning, and we can try to impose anatomical constraints. So on the feature constraints and putting robustness into this, for instance, by trying to build systems that are invariant to where the data is coming from, I just want to illustrate this with a quick schematic here, what the problem really is. And if you think about, for instance, training data coming from one side, that training data might often be biased, or it might have features or patterns in there that are actually not the ones we are after. So this is discussed a lot in the context of so-called shortcut learning, deep neural nets. You can find more works and discussions about, for instance, in this work. But just to illustrate this, so what might happen if we would train a machine learning algorithm on data that comes from a site A here, so that if this is our training data, then an algorithm might just pick up to do a classification into benign and malignant by looking at the color of these structures here. Because color is really easy to pick up, for instance, for a CNN. It's a simple readout of the intensity values at pixels. It's a shortcut, and it's a shortcut that gives us a very quick decrease in our loss function. So this is a feature that will probably be picked up if we just give it this type of training data. Now, then we might face at test time data like this, where we see that color wasn't actually the right feature to use. It was rather shape that would tell us whether something is benign or malignant. But shape generally is a much more complex feature to extract. So we need to put more effort into the learning to extract the right types of features to describe, for instance, the shape differences in the boundaries here. So this is just illustrating what can happen at a setting where there's a mismatch between our training and our testing data. And there are a lot of ideas how to circumvent this. So there's domain adaptation, domain generalization, adversarial training. And I talk about this, or I talked about this a little bit more in a presentation at MIUA last year. So if you're interested in the type of works and solutions or ideas one can use to tackle this problem, please check this out. But today I want to focus a little bit more about the other line of works, which is about putting anatomical constraints into these machine learning algorithms. And we can do this in different ways. So we can look at implicit versus explicit constraints, and we can look at training time and post-processing. So let me start with some work by Ozan Oktay, who was a PhD student and RA in our group a few years ago. He's now a research scientist at Microsoft Research Cambridge. And he has been working on these anatomically constrained CNNs, or ACNNs. And the idea here is, so the task that Ozan was working on back then was a joint task of super resolution and segmentation. So the main application was cardiac MRI, but it was also applied to ultrasound. But let me focus on the cardiac MRI example here. So typically in cardiac MRI in clinical practice, for instance, for short axis scans, we might get these scans that have high in-plane resolution, but low out-of-plane resolution. So you get this stack of slices where along one dimension you have thick slices, so low resolution. So if you wanted to extract segmentations from that to make, for instance, measurements about the anatomy, that is quite difficult, also due to, for instance, motion artifacts that you might have between these thick slices. At the same time, we might want to super resolve that image to have a better visual perception of the anatomy. Now, if we are just using standard supervised learning, for instance, to do CNN-based super resolution or CNN-based image segmentation on the low resolution scans, these are the results we are getting on this type of input data. So in the first case here, for instance, because of some motion artifact, we get a discontinuity in the anatomy. So this is not anatomically plausible super resolved image of the anatomy. On the other hand, the segmentation here is very blocky. It again doesn't resemble what we would call an anatomically plausible segmentation. Using ACNNs, Ozan was able to extract very accurately results that are anatomically plausible, both for the segmentation and the super resolution. And let me show you how this works, how this was being done. So the idea here is to encode anatomy into the neural networks and use this as a regularization term when we solve the task. So how does this work? So here, what we're using are so-called TL networks, which are basically a combination of two different networks that are trained jointly together. So on the bottom part, we have an autoencoder that takes in segmentation label maps, encodes them into a compact representation, a Latin code H here. And from that code, we can reconstruct the original label map. So that's just an autoencoder that takes in label maps, computes a low-dimensional representation, and reconstructs the original label map. On the other hand, we have a predictor network that takes in intensity images. So this one takes in high-resolution intensity images and produces also a compact representation and of the same dimensionality. And this compact representation should be similar or almost identical to the one that we get from the autoencoder over the label maps. And this is achieved by putting an Euclidean loss between those two representations. Now, what this means is that if we train this TL network, both on high resolution intensity images and anatomically plausible segmentation maps, is that we learn this anatomy representation here, which lives in a lower dimensional space, that is being mapped to both from intensity images and segmentation label maps. Now, if we use these components for our task networks, so let's say we want to solve the segmentation task, so a low resolution image goes in here, we want to segment it to get segmentations that are anatomically plausible, we can feed them to these encoders. So these encoders are now fixed, so these are basically pre-trained. Only the segmentation network is what we are training for here in this case. And this encoder network is now producing this low-dimensional representation of our segmentation output. And it also does the same with the ground truth labels. They are also fed through the same encoder so that we can put, again, an Euclidean loss on those encodings and say they should be similar, right? And in addition, we train it with our standard segmentation, for instance, a cross-entropy loss. So this acts as a regularization on the type of segmentations that this network can produce. And if you remember, this encoder has learned to take in high quality, anatomically plausible label maps, produces a code from which we can reconstruct. So if these two codes are similar, then we should get a segmentation here, which is anatomically plausible. And similarly on the super resolution task, so here the goal is to learn a CNN that can super resolve these low resolution cardiac MR images. We take the produced high resolution image and we give it to the predictor that was pre-trained, right? And remember, this predictor has only seen high resolution images and maps them to the same latent space, the same embedding where anatomically plausible segmentations live. So this high resolution image is fed through the predictor. And again, we put a regularization term, an Euclidean loss on these encodings by also encoding a ground truth high resolution image, the matching one to this one. Now you might wonder, so why can you produce a high resolution cardiac MR image here in the first place? Because you can, but it's just very time consuming. So in clinical practice, you would want to avoid to get a scan like this, but you can do it for your training data. Right? And again, what this now means is that these predictions from the super resolution network need to be anatomically plausible because we put a constraint on the embeddings that are produced when feeding the prediction through this pre-trained network from the TL network. And here looking at some visual results, so the ACNNs do indeed give us much more anatomically plausible outputs, both for segmentation and also for the super resolution, even if there are quite a lot of motion artifacts in the original low resolution scan. So this is really nice. This gives us an implicit way of encoding anatomy and something anatomically plausible into our neural networks. It's acting as some sort of regularization term. We can also look at the learned embeddings, the learned representations for instance, the cardiac left ventricle case here. And similar to PCA, what we can do is we can look at the modes of variation, and we can understand better or do some interpretation on the learned encodings and see that there's some meaningful variation encoded. And interestingly, we can also use these embeddings, for instance, to do disease classification. For instance, if we compare this to running a PCA over our segmentation label maps versus looking at the encoding that we get from a TL network, and then use them in a separate task where we have disease labels for patients, we see that those representations are quite useful, for instance, better than a PCA embedding to do disease classification. So this is really encouraging. Another way of putting anatomical constraints has been done in this work with Enzo Ferrante, who was a postdoc in my team, who's now a professor in Argentina, and together with his team, where I was very fortunate to collaborate with, we looked at denoising autoencoders. And this is for a post-processing. So if you have a segmentation method that produces a segmentation prediction, but that one might be noisy, you can use post-DAEs to clean up that prediction. So these post-DAEs have also been trained on basically cleaning up, restoring from noisy predictions to get something anatomically plausible. So you can use them as a post-processing, as an add-on to any segmentation method that you have. So for instance, in this work, we looked at various different types of segmentation algorithm, for instance, random forest and different types of UNets and different tasks. So binary segmentation from chest X-ray, multi-class segmentation from chest X-ray, and also cardiac segmentation from MRI. And what you do see if you, for instance, compare this to other post-processing techniques like CRFs, conditional random fields, you do get results that are more resembling closer the ground truth in terms of being anatomically plausible. A CRF also gives you a cleanup, so it does reduce the noise in the predictions, but the cleanup is not necessarily constrained in a way that it gives you anatomically plausible outputs, while the post-DAE has learned to clean up in a way that you get something that is closer to the true anatomy that you want to get out. If you compare this quantitatively, for instance, post-DAE head-to-head with a CRF type of post-processing, what you do see in these plots, for instance, in the top row, you have dye scores before and after the post-processing, and here you have host-off distance before and after post-processing. So for the green dots, the post-DAE dots, are typically above the diagonal line, meaning that they made an improvement, or they are below the diagonal line for the host-off distance. They made an improvement on the segmentations, while the CRFs are often not as good as a post-processing step. Now I want to talk about a more explicit way of putting anatomical constraints. So this is very recent work with Matt Sinclair from HeartFlow and others, where we looked at a method which we called Atlas ISTN. So ISTN stands for Image and Spatial Transformer Networks, where we want to very explicitly put anatomical constraints. So we want to make sure that the segmentations we get out, again here on cardiac, but this time cardiac CT data, is anatomically plausible. And the way this works, so Atlas ISTNs are basically combining the more traditional segmentation methods, for instance, a UNet that does a dense voxel-wise classification here, which might sometimes be noisy. You do sometimes get these spurious results outside the region of interest. It is combining it with a registration-based approach, a learning-based, registration-based approach that uses spatial transformers to map images on top of each other. Now in Atlas ISTN, what we do is we jointly do segmentation, registration, and Atlas construction in the following way. So if you have a training data set of images together with label maps, what we now trained for is a segmentation network. So think, for instance, this to be a UNet, where you have a loss function that just says you have to do segmentation on these images. And then we feed those segmentations through a spatial transformer. And the spatial transformer tries to match the current segmentation that is being produced to an atlas. And the atlas is being iteratively updated over the course of training. So we start like in the typical way of maybe just averaging all the label maps that we have in our training data. So we get a very blurry atlas initially, but it gives us a guide to do the registration and to more and more finally update that atlas and become sharper and sharper over the course of iterations. It also means, because we can back propagate through this entire chain, that we basically have an alignment between atlas and current segmentation after it's being warped, for instance, by a diffeomorphic transformation, that we can back propagate back even through the UNet. So the UNet is now being encouraged to produce segmentations that afterwards can be better registered to the population atlas here. And we get this in both ways. So this transformation is invertible. So we get both a mapping from the atlas back to our segmentation and the segmentation back to the atlas. So this atlas is iteratively refined during training. But interestingly now at test time, so this is after training, we can feed in a new image that we want to segment. We get a UNet type segmentation that might have some mistakes. It might have some spurious output, but that segmentation will also be registered back to the atlas, and the atlas being registered back to the segmentation, because we have this invertible transformation, that we now basically get two outputs. We get the UNet segmentation, and at the same time, we get a aligned atlas. The aligned atlas is anatomically plausible because we're using diffeomorphic transformations here. We will never deviate from the anatomy that is defined in atlas space. So we will definitely get something anatomically plausible here as a warped atlas. And we find that often this atlas is giving us better segmentation accuracy than the UNet. But in any case, it is one way of updating this segmentation. And interestingly, because at test time, we can now run refinement. So we don't just have to live with a one-pass prediction of this spatial transformer network. We can now actually iteratively update the alignment of our UNet output in our atlas, such that we refine this transformation and get an even better alignment of the atlas to our original image that we want to segment. And this has shown to actually work really, really well. So just to illustrate how this might work, I'm showing you some synthetic data here first. So this is a letter B example where, for instance, we have these synthetically warped letters with noisy images. If you start training initially, our atlas would just look like a blurred instance of that letter B. So this was the base letter that was used to create that data set. And after running Atlas ISTN training, we get a final atlas which closely resembles the original letter here. And now at test time, what we can feed in are corrupt images that have never been seen at training time. So we haven't seen this type of noise and corruption in the data beforehand. So if we use such data at test time, what happens is quite interesting. So a UNet, so in this case, this is called the ITN part, the image transformer network, but it could be just a UNet, will produce a segmentation that correctly segments the parts that are valid, but it will do mistakes for the noise because it doesn't know how to deal with that type of corruption. So it will have these missing parts and these extra segmentations. Now, the atlas will already, after the one pass through the STN, give us a more anatomically plausible or geometrically plausible segmentation of the letter B, but it will not be super accurate. So if we compare to the ground truth segmentation or the ground truth structure here, these are the difference images between the UNet and the one pass atlas. Now running the test time refinement shows how powerful this Atlas ISTN framework is, because we can now, for instance, run the refinement of the transformation parameters of the STN and get a very, very plausible and accurate segmentation out of that letter B. Of course, depending on the regularization term that we have to choose here, we might get slightly different results. And that is something that we might have to think about how to fine tune. But you can see that you can, at test time refinement, get very plausible segmentation even for this heavily corrupted image with these Atlas ICNs. Of course, we have done this on real data, so we were interested here in cardiac CT segmentation of the major structures of the heart. So it's a multi-class problem. Here are some examples of good segmentation, good cases where everything works reasonably well, even with a UNet. So this is to illustrate that the Atlas is being on par when the data quality is high. You get similar results even after one pass Atlas warping and the refinement. They all give you very reasonable and high quality segmentations. However, if there's a bit of noise or some artifacts in the data, for instance, where the UNet would predict some structures outside the region of interest, that's where you can see where the Atlas ICN shines and basically repairs that output and gives you only something anatomically plausible. These spurious predictions will have an effect on the one pass STN, so you might get a misalignment between the Atlas and the structure you actually want to segment, but then the refinement comes in and actually does an accurate alignment afterwards. And here's a more severe case where the UNet is over segmenting parts because of the image quality or the image noise. And again, putting the Atlas on top of the UNet segmentation gives you a very plausible and constrained segmentation that are very close to the ground truth here. So this is a very explicit way of putting anatomical constraints and making your segmentation network or your segmentation task much more robust. So in the next part, I want to talk a little bit about reliability and some works we've been doing on trying to improve algorithms reliability. This is about capturing uncertainty both in the training data in the first place, but then also estimating uncertainty of our output predictions. And we'll see that some of these techniques also help us in improving the calibration and the predictive confidence in our predictions. The first work I want to talk about is spatially varying label smoothing. And here, so what we generally observe is that, I guess everyone would agree that segmentation generally is an inherently ambiguous process. If you, for instance, ask 4 different experts to segment these lung nodules, you get 4 different answers each time. And there's quite some variation between expert segmentations. So we have to embrace this uncertainty and this ambiguity. Now, one simple way of capturing the uncertainty that is already present in the label maps is spatially varying label smoothing. The work Mobarak Islam was working on, a postdoc in my team, and this has been just presented at IPME a few weeks ago. So here, basically the idea is to directly extract some ambiguous information or uncertainty from the expert label map. So here illustrated with these simple examples. If you look at this side and this side, what you see that is in this image, which is a 3x3 label map, you normally in a one-hot type of encoding that we typically use to train segmentation networks, you would have a label that would be 100 if you have 3 classes. However, if you look around in the spatial neighborhood, you might actually have some information about that other classes are also likely to happen in this area. So for instance, you have quite some evidence that the green class is there, and maybe there's a neighboring pixel also from the blue class. So you can use label smoothing. So label smoothing is a technique that's been used in computer vision, for instance, for image classification, where you just downweight a little bit the weightings you have on your labels, and you do this uniformly. So you downweight your ground truth label and you distribute the remaining probabilities over the other classes. In spatially varying label smoothing, we basically take the spatial information into account. So we just look at the neighborhood and count how many occurrences are there for the different classes and take this into account into our weighting. So a spatially varying label smoothing would give us this labeling for this central pixel. And in a different example, you would then get different weightings. So these will change depending on your spatial location. And this is a really simple and straightforward way of capturing uncertainty. And it's interestingly, we will see how much it helps with calibrating our neural networks. But it can also be easily extended, for instance, to the task where you have multiple experts. So if you have 4 experts giving you 4 different segmentations for a single image, you can take this into account, and you can see how the spatially varying label smoothing differs from a simple aggregation of the central pixel information, for instance. So we have tested this for various segmentation tasks, and you can find more details in the paper, but just some visual results here that confirm that we do preserve in our predictions, I think more reliably the underlying uncertainty. More importantly, if we look at the calibration of the network, so if we look at how the confidence of the predictions relate to the actual accuracy, so you can compute these curves by binning your predictions, your samples over buckets of confidence, and then see how many do you get correct in each of those buckets, you can produce these curves. You see that both spatially varying label smoothing and label smoothing do help quite a lot with calibrating. So the orange lines, if you see, are the one-hot encoded networks. They are often miscalibrated and quite far off from the diagonal line. And if you use label smoothing, you get better calibration. So that means that your output predictions are much better calibrated with the true accuracy. So you can more reliably, for instance, use these confidences to say whether a network might fail or might not fail. So that is something that we need to further investigate, but generally you do want to have better calibration so that you can use the confidence estimates from your models. Another way of capturing uncertainty is in the output space. So this is a work by Miguel, a PhD student and RA in our group. He recently developed this idea of stochastic segmentation networks, which is actually, again, relatively simple and a nice add-on that you can put on existing neural networks. But just to motivate this a bit, let's look at what a standard segmentation network would do, where we have the logits that are then turned into probability maps for each class labels. These logits that are produced per pixel are actually independent. So if you would model the distribution over those logits and you would sample from them, let's say you want to see what the distribution is over those predictions, the pixel-wise independent predictions, you get basically these noisy samples, right? So there's no spatial coherent information in those logits. So in stochastic segmentation networks, the idea is to basically make these logits dependent on each other. And we do this by using a low-rank multivariate normal distribution to model the interactions between logits. And that can be put as a layer, as an add-on layer on any segmentation network. You can put it on a UNet, on a DeepMedic, on whatever is your favorite architecture. What it allows you to do now is to sample different output predictions. So here you see how the samples do show spatially varying and spatially consistent variations. And the idea behind SSNs is to be able to produce multiple plausible segmentations that are diverse. So if we, for instance, now look at a few examples here, so there's an input image from the Bratz data set, this is the ground truth segmentation, this is what a deterministic segmentation network would give you that just produces one output. This is what the mean looks like when you take our SSNs, and then you get different samples. And from those samples, you can then also get a measure of uncertainty, right? So for instance, here we're showing the entropy plots, which are telling you something about how variable the predictions, the samples are in different regions. So that is a nice way of capturing the uncertainty in segmentation networks. It also gives rise to this idea of doing interactive manipulation. So you can use the low-rank modeling, the low-rank model of the distribution of the predictions to do interactive manipulation. So there's a live demo online in the GitHub that you can check out. But you can basically, a little bit similar to a PCA where you change the modes of variation, you can think of a slider that you would tune and interactively manipulate to change your output predictions. That might be actually a quite interesting application in settings like radiotherapy, where you have a human in the loop in the segmentation process. So the network produces something, and then afterwards you have a human expert being able to do some refinements on those predictions. What was interesting to see is that the SSNs were the only network in our experiment where we compared, for instance, with other approaches like PISEC and probabilistic UNet, which are also trying to model the distribution over segmentation outputs. The SSNs were the only network that were benefiting from being trained on multiple annotations per image. So in the case of LIDC, where you have multiple segmentations of lung nodules, we saw that in the DICE course, the only model that actually benefited from being trained on all sets was our proposed SSN with the low rank modeling of the distributions. So that was quite encouraging again. So I've been talking about robustness and reliability and different ideas for improving this. You might have seen many other works that work in that space. I want to talk very briefly a little bit about this aspect of quality control and input safeguards and the output safeguards that we might be able to put around AI algorithms. So first of all, I think the safeguards via quality control can be kind of separated into two parts. As I said, pre-analysis QC. So we might want to be able to say in advance whether an image is analyzable, or we do post-analysis QC, where we want to say whether the predictions are valid. So what is the validity of the analysis? There are many applications for these type of safeguards: failure case analysis, quality monitoring. It might have relevance for regulatory inspection of AI algorithms. So this is some work from Giacomo Taroni, who's now a professor at City University London. He's been working on this when he was a postdoc in biomedia, which is a nice work on pre-analysis QC that was applied to the UK Biobank data. Just want to mention this work. So this is, of course, very application specific, but there were different things that could be measured automatically from the images and the segmentation outputs, or using some sort of segmentation outputs to do quality control on the images, on the raw images, and feeding back about the image quality. This is really important in large-scale studies like the UK Biobank. For instance, what we could see with Giacomo's system is that there was a shift in the coverage of the heart in the UK Biobank cardiac MR scans. So this was done over 20,000 scans between different sites. So there are two different, now three, I think, different sites where they acquire the data. You can do, for instance, a site-specific analysis and see that generally Newcastle, I think, who joined later as an acquisition site, had generally a higher coverage of the heart in the cardiac MRI scans. In particular, I think Chile had in the beginning, so you can also do this by time, had in the beginning some issues where sometimes the heart wasn't fully covered in all the cardiac MRI scans, and then over time this got better and better. You can do these analysis, of course, while you are acquiring data, so it might actually be useful to give this like as a live and real-time feedback to the person who's doing the image acquisition. Another work I want to mention, this is about the post-analysis QC by Vanya, who has been doing her PhD in our group on automatic failure detection. And she's been developing the system, which we call reverse classification accuracy. But the motivation for this was to come from this, to break out of this cycle of where we normally just do developments on our methodology. We do cross-validation and testing, and then every other iteration we can write a paper about our new results. But eventually we have to face reality and have to say, what happens if we actually, let's say, deploy a segmentation method in the real world? Now, in the real world, there's no ground truth, or at least it's not available. So how do we know, for instance, if we do segmentations with a neural network, and then we get something out on which, for instance, we do quantitative measurements, how do we know how good are those results really in the absence of ground truth? So this is where RCA comes in. The idea of RCA is actually quite simple again. So we take the training data initially to train a machine learning method, for instance, to do image segmentation. We then deploy that method. And what do we now do with these predictions? So we can take an individual prediction, so a per subject prediction, and just use that prediction together with its image to train what we call the reverse classifier. So this could be a small neural net, it could be a random forest, could be Could also be just an atlas-based registration depending on the task. But let's say this is a small neural net that takes in just that image and the prediction and is being trained, basically overfitted to that one sample. What we then can do is we can use that classifier and test it on all our training data. And we go through each of those training images. And what we do is we see how well can we predict the training data. Now, how does this help us? So the hypothesis here is that if this prediction was good, then we should be able, with this overfitted classifier, to at least find one, maybe a few cases on the training data on which we do reasonably well. Now, on most of them, we will fail, obviously, because this is not a generalizable prediction model. But a training data that is close enough to our test image here, on that one, we might do reasonably well. And we can take, for instance, compute die-scores on that training data. And if this die-score is really high, we have a good confidence that this prediction was good in the first place. Otherwise, we would never reach a high die-score on a training example. If we fail on all of the training examples, we have an indication that maybe this prediction wasn't really good in the first place. So that is a way of trying to predict how good that is. And whether this works, we have tested again in a large-scale study. We used the UK Biobank cardiac MR data, where we had many thousands of segmentations in a system for segmentation quality control. So here, for instance, in the first simulated setting, we used a random forest, which we artificially degraded by limiting its depth to produce different quality segmentations. And what we could show in these scatter plots is for different segmentation metrics, we were able to quite accurately predict the score. So the ground truth score is on the x-axis, and the predicted score is on the y-axis. And you see that the predictions do correlate quite well with the real scores. We then also tested this on a CNN that we knew was of high quality because it had been manually quality controlled and visually checked the segmentation results. So we know that the CNNs would perform reasonably well on the segmentation, and our RCA approach could also confirm this by predicting for most of the cases high die-scores, low surface distances. So these are just examples of safeguards that we can put in. I think there are many more that you can think of, but just showing that there is work, and that I also think that there's more work needed on developing methodology, not just to improve the AI algorithms itself, but to put reliable safeguards before and around these algorithms. Now, I just want to finish with some thoughts about transparency and explainability. So we have been recently working on a perspective where we brought in some ideas about how to use, for instance, causality to better understand challenges and limitations and pitfalls in machine learning. So I invite you to have a look at this paper, Causality Matters in Medical Imaging. But one of the outcomes was that we found is that if we take a perspective on trying to model the data generating process, we can reveal a lot of the potential problems that might arise when we do machine learning in medical imaging. For instance, the direction of causality between the image and the target, whether we want to predict the diagnosis or we want to do a segmentation task, actually matters. And it matters in a way that different challenges arise and different solutions are also available that we can consider. We also discuss in this work how different types of shifts play a role: annotation shift, acquisition shift, population shift, prevalence shift, how we first of all can name different types of shifts that might happen between our development stage and the testing stage of our algorithms. And then we propose or look at different ways of tackling these problems. Some of those shifts are really, really difficult to deal with. Another important aspect is sample selection. We obviously often have biases in our training data that we need to take into account. Otherwise, the systems will not work well and not generalize to new data. I just want to finish with one outlook, a recent work where we looked and used causality in a slightly different setting to generate images. So think about the problem where you have, for instance, two subjects, same age, 68 years old, and then you look at a follow-up scan and one of the subjects changes 2 years later on. So if I go forth and back here, you see this maybe in the difference maps even better. And we might ask questions like, what if, why are they different? And what if subject A had a different lifestyle, different medication, would they look differently? How can we answer such questions? What if questions in medical imaging? So this is some nice work by Nick and Daniel, who have been using deep learning in the setting of causal models. So we worked on this work called deep structural causal models for tractable counterfactual inference. We used a relatively simplified causal model for generating brain images. So this is an assumption we made that an image comes together by looking at different covariates here. And we looked into how we can use deep learning to model this. So there's a bit more work on this, and I invite you to have a look at the paper to go through the technical details, how we set up the structural causal models, how we can learn from observational distribution these causal models. But I just want to highlight here that this is exciting because we can now do the following. So we can take large-scale observations from large studies. We can fit our probabilistic model to faithfully represent the underlying distributions. We can then make actions, so we can do interventions, so we can use the do operator to change certain values in this structural causal model, and we can then make predictions on this. So this gives rise to counterfactuals. And we have been using the UK Biobank brain imaging data here, which has a lot of data which you do need in these type of studies. And we could show that our model, the deep structural causal models, could faithfully represent the underlying data distribution. So for instance, we see the differences in brain volume over age, over biological sex variables, and this is faithfully represented. So that is one way of confirming that we learned the distributions correctly. But then more excitingly, we can do counterfactuals. So we can, for instance, take a subject. So this is now an analysis, not on the population level, but on the subject level. So this is important. And then we can do interventions. So for instance, we can do all types of different interventions on the different covariates. So just to show you some very interesting ones. So if you do, for instance, intervene on age, so this was a subject 49 years old. If we make them slightly younger, you do see that the brain overall increases a little bit in size, but not too much. That's almost no difference. If we make them significantly older, we see that overall the brain shrinks. However, the ventricles do get a bit larger, and that is what we do also observe generally. As people grow older, the volume of the ventricles gets larger. But this is really a faithful intervention, because if we would just intervene, for instance, on brain volume, so let's say we make the brain volume smaller, going from 1,100 to 800, the overall brain volume shrinks, also the ventricles shrink. And if we make them larger, everything gets larger. If we are just intervening on the ventricles, then everything else remains stable, but just the ventricles change. So what is quite remarkable is here that overall, we feel the identity of the subject is preserved, the cortical folds are preserved. So we're making specific anatomical changes here to these synthetically generated images, which seem to be faithful. But of course, there's a question about the validation. How do you confirm that counterfactuals are actually correct? But it just gives you an outlook where this could go and where causality could come in. It could help also with explainability. So that is what I wanted to highlight. Imagine you do this in a setting where you have a disease label, and you could change and intervene the disease label and change, for instance, how an Alzheimer patient's brain would look like if they hadn't had Alzheimer's, and you might highlight certain regions that are related to disease. So there's also an online demo for that, so I invite you to check that out. But I want to conclude here and just give you basically a summary of saying that there is work in all these fields, but not enough. I think we need to do more. We need to look more into the components that makes AI safe for clinical practice. And I hope we can have a discussion now on what else is needed, what is missing, and where should we go next. So many thanks for listening, and I'm very much looking forward to the discussion. Thank you.